we will give now the microphone to our champions, because now the work will be maybe to Stephen Willems to convince you that the point-by-point is at least equal or even better than the single shot. So it is now my pleasure to introduce the first champion of the debate, Richard Schilling from London, will advocate for the single shot tools. Richard, thank you.
I've got a pointer. So thank you very much, Serge. So I'm not the Boston Scientific champion. I'm the champion of all the people here at the back away from the clever tables, because I'm a very simple man and I have very simple capabilities, and I can't achieve what the brilliant professors like Isabel managed to achieve with point by point. So I have to resort to try and solve these three problems in a different way, because certainly in the UK, we have a massive problem with demand. We have long waiting lists. I can see people nodding at the back. Long waiting lists, patients saying, when are you going to do my ablation? We have limited numbers of centers. I've got colleagues that come up to me today and said, have you got someone that I could appoint? I need to find some more people. Again, I can see people nodding at the back. And then we've got a really technically complex procedure that we're using to address these two problems. Now, at the very beginning of this, if we knew that the problem arose in the pulmonary veins before we'd invented ablation catheters, if we just knew that the problem originated in the pulmonary veins, do you think we really would have invented a thin wire that delivered red-hot energy into the wall of the heart and said, this is a really good idea? Of course, radiofrequency has just come to being as an adaptation of something that was already there. If we knew that this was the problem at the very beginning, we'd have never used radiofrequency. We would have invented something else. And then we said to ourselves, well, what we need to do now is we need to take this red-hot poker, we need to push it through the wall of the heart into the left atrium, and then from the leg, we need to then do a series of burns, point by point, that manage to join up and electrically isolate those pulmonary veins. Are you mad? Why does that make any sense whatsoever? And for a few years, before brilliant people like Isabel got going, the surgeons were almost going to take this from us, because, of course, it made more sense to cut the patient's chest open and use a clamp to burn the veins than for us to use a red-hot poker to do the burns from the inside. And without people like Isabel and their brilliance, this would have never got going, because it just doesn't make any sense. Now, I think that I've already convinced you that this is a bad idea, but I'm going to show you some data just to help support my argument. So here we can see complication versus operator volumes, and everyone's very familiar with these data. They've been shown in a number of different ways, but we can see that if you do less than 50 a year of these procedures, then your operator complications are much higher than if you do more than 50 a year. Now, the problem is that it's very rare for someone to stand up on this stand and go, oh yes, I've got lots of complications. So the shy people at the back, like me, will be sitting there, well, you know, I've got high complications, but I'm going to get better. I'm going to listen to Stefan, and I'm going to get better because I'm going to learn what he's done. What you should be doing is listening to me and saying, of course you're going to get high complications if you're waving a red-hot poker around in someone's heart and you're not doing that many. But you need to get over that hurdle. You need to get over that threshold. Of course, to be able to do lots, you need to do a few to start with. So why would you start with the most complicated technology that you could possibly use? Well, the reason you have to start at the moment is because of this. AF ablation, this is from 2013, and it's even growing exponentially now. The demand for AF ablation is growing. And the demand for angioplasty is flattening out, because angioplasty, as we all know, is a treatment for symptoms, whereas AF ablation reduces morbidity and mortality. No? Okay. And so PCI is flattening out, and patients are demanding more and more AF ablation. So we need to try and solve this problem. And one-shot technologies are the answer. So these technologies will allow you to use a soft, atraumatic technology to push it up against the outside of the vein. It will allow you to burn or freeze, and in an atraumatic way, and monitor the outcome of your approach. Now, one of the problems with this has been that there's only been one player in the market with a very predefined technology, and I'm very pleased that there's competitors coming in now that have slightly different characteristics, which may make this even easier than it is right now. The advantage of the balloons, of course, is that they, as I will show you with some data in a minute, give you a reasonable outcome over a wider range of skill and experience. Now, for people like me, who makes my living from AF ablation, on the face of it, this would seem like a bad thing, because it means that other people can do it more easily, which means I'm going to have less work. Well, let me assure the clever people that don't worry about it, because there's plenty of work to go round. You don't have to continue to make it complicated. It's actually, there's so much work to go around, we're not going to have a problem. The other advantage is there's a broad lesion width. So when you do isolate, you tend to isolate robustly. And it's fast. So these are data from a non-surgical center from about 300 patients. And what I would really draw your attention to is the standard deviations. So this is the thing that makes it easier to address that problem, when can I have my ablation? Because you can guarantee that that patient will have their ablation within 65 minutes. There's no complicated patients. So it's very unusual for cryo or balloon ablation to go on longer than 70 minutes. And the reason these guys are quick is because they're doing just this all the time. They're not having a pacemaker in, they're not doing a bit of red-hot pokery. They're just doing cryoablation, and they're doing it really quickly, which means they've got very small standard deviations. Now, the thing that changed my mind, because I was exactly the same as all the clever people, apart from I wasn't clever, I believed that radiofrequency must be the right way forward, because I can do it quite quickly. Of course, I don't need to use a cryoballoon. I can do radiofrequency really quickly. So I did a trial about 8 years ago, where we took patients with paroxysmal AF and we randomized them to 1:1:1 with wide area circumferential ablation, cryoablation, and then my belief, I was so arrogant, I thought, well, radiofrequency is going to be so much better than cryo, but how about if we combine the two so that the advantages of cryo and the advantages of radiofrequency will be shown in the same patient? And this was during the cryoballoon Gen 1. So this is the sort of lesion set. We did a wide encirclement to isolate the veins, and then did supplementary cryoablation, so they had both. And this is the result that really surprised me, because cryo was so much better than RF on its own. It was only when you combined them that it got a bit better, and it wasn't better enough to justify the cost of doing both radiofrequency and cryo. And of course, outside in the corridor, I could hear the patient saying, please, when can I have my ablation? And so we couldn't afford to spend the time doing radiofrequency and cryo, because we had patients queuing up down the corridor of the hospital. So this is what made me convert to cryo, was this trial. Now, I'm not the only one. In many registries and trials, they've now shown that cryoablation is either better or pretty much the same as radiofrequency. This is German data. In this study, the cryoablation was so good they can't even fit it onto the top of the slide. The results are so good. So this is a multi-center trial of cryoballoon versus RF. And granted, this is next-gen balloon against non-force sensing. This is the Swedish ablation registry. I'm going to spin through these because I've already convinced you by the sheer logic of the argument. But here again, you can see the logic is backed up by the data, that the reablation rates are much lower and the cryoablation is much better than the RF. Now, one of the reasons that I tend to ablate patients less after cryoablation is because I know I'm much more likely to get the patient back with all four veins isolated, which is really depressing. So I'm now anecdotally starting to have a higher threshold for bringing patients back for ablation after cryoablation, just because I know it's going to be a slightly depressing procedure. What do I do next? In this slide, from the same registry, you can see that cryoablation is better than radiofrequency for pretty much everything. But the interesting thing is it's just as good for persistent atrial fibrillation, which backs up what STAR AF told us, that actually at the moment, unless you're an absolute brilliant ablation physician like Isabel, we don't know where to burn. So people like me don't know where else to go. And so, Stefan, who is of the same level and brilliance as Isabel, will come up and say he does, and of course he does, but people like you and me don't. So why wouldn't we use the simple cryoablation technology? I'm going to spin through the last few slides fairly quickly, but this is the FREEZE trial, where they cluster randomize patients to cryoballoon or radiofrequency. And the really interesting thing is that cryoablation, as we would expect, is safer because it's a more atraumatic technology. It's what you'd expect it to be. But interestingly, although it comes out very similar in terms of outcomes, there is a trend to cryoballoon ablation patients having a better outcome at follow-up than the radiofrequency ablation patients. So they had similar outcomes. Cryo was quicker. They had a slightly higher radiation dose, but you can get that down with attention to detail. And they have an equal outcome for persistent AF. So they have low risk for both, but it was lower for cryo. And here's the really important slide for everyone like me, a normal human being. The less experience you have, it makes no difference for cryo. The outcomes are exactly the same whether you're experienced or you're not. And that may worry us, so, well, what's going to happen to all our work? But as I said before, don't worry, there's plenty of work out there. The more we do, the more we'll find, because we're not even therapy developing. So let me ask Stefan before we finish, what would you may remember, we're of a similar generation, you remember the space hopper. What would you rather have bouncing around in your heart, a lovely balloon that may warm or freeze your heart, or a red-hot catheter? So in conclusion, I would say that single shot is an ideal technology. Balloon technologies are an ideal technology. They level the playing field. They make it harder. Not impossible, but they make it much harder to make a mistake. And why wouldn't we want to keep our patients as safe as possible? They make the procedures more predictable, and they do exactly what we need and no more. They isolate the pulmonary veins and treat the patient's AF. Thank you very much for your attention.
It's the turn to our second champion, Stefan Willems from Hamburg, who will give us his thoughts and his arguments in favor of the historical, the point-by-point ablation strategy. Thank you, Stefan. Thank you.
Thank you very much.
Thank you
for the kind introduction and for the kind invitation. Of course, it's a very, very difficult task. I mean, you have all already decided before I appear here. And in the introduction, I was called the historical guy. I mean, what kind of introduction is that? Very nice, thank you very much. And third, last not least, I have a very smart, a very brilliant, persuasive, well-respected opponent. So what should I say? I would like to say we'd like to collect some arguments, and we'd like to have a closer look and see that this guy really threw sand in your eyes. That's what he did. He confused you. He didn't show, maybe you have recalled it, just very sparse randomized data, but he showed some nice images with balloons and toys and tools and everything like that. But now let's have a look at the data. And apart from that, some results of the world of sports are also encouraging me. I don't want to stress that any further. So let's have a look at some data. So if we collect that and if we compare it, it's clearly, and you've heard that already in the talk of Isabel, it's really the question of fire and ice, basically. Also the question about what kind of energy we use. And if we have a look at the situation in Germany, it's interestingly the opposite of what you just voted. So that 2/3 of the ablation procedures are performed still with RF, the rest with cryo. So yeah, 2% other things. So we don't have to talk about that. So are all these people doing wrong things or the second best option? I don't know. Let's have a closer look. First point, effectivity. Richard told you cryo is more effective than RF, but let's have a look at the real randomized data which are available. And of course, I was surprised that he didn't, because I just brought one slide because I thought he would take like 10 of them, of the fire and ice trial. But I'm happy that Isabel already showed it. So there was a non-inferiority of cryo, but as we heard already, second generation cryo, first generation RF. And this was equal. Okay, 1-to-1. If we have a look at smaller data like our own data, comparison cryo versus walk the line approach and thorough putting a thorough ablation line, there was in the short-term and long-term follow-up, there was no difference apart from the fact that early recurrences were slightly earlier with RF, but on the long term there was no difference even after 1 and 2 years in subsequent publications. If we have a look and summarize that, and I was also surprised that he didn't show that, if you put all the randomized trials together, you see exactly at the line of unity, you see the effectivity result. So there's completely no difference between the two strategies with regard to effectivity. Now let's have a look at the very recent data. And you saw data from 2015, 2016, but now let's have the very current data. And you see with implanted loop recorded equipped patients, irrespective of the mode of ablation, the result is completely the same with regard to recurrence of atrial fibrillation, cryo 2 minutes or longer cryo or RF ablation. Completely no difference. So it's really 1-to-1 with regard to effectivity, first argument. Now let's collect some other arguments, pro RF, pro cryo. Let's have a look at the procedural data, and you just saw very sparse data on that. Use of fluoro, use of contrast media, and of course procedural time. I asked you, what is important for the patient? Is it the procedural time? It's important for you and for the hospital suppliers, and maybe regarding the economic burden, of course. But for the patient, it's interesting and relevant that she receives the best treatment with the lowest amount of fluoroscopy and the lowest amount of contrast media you can offer. And that's not cryo. Let's have a good look to fire and ice. Procedure duration, of course, slightly longer. But fluoroscopy time, significantly longer using cryo. And if you go now to more recent data, this is again from our own experience, own hospital, you see again procedure duration, fluoroscopy time significantly lower, but also the use of contrast media is higher, much higher in the cryoballoon. And now going back to the advances of RF ablation and integration of images, you can reduce fluoroscopy even further. We know that, and we can go down. The most recent publication now, again, the circa dose trial, and you see that the fluoroscopy time is 1/3, and this just came up 1 month ago. So there is a 1/3 fluoroscopy load for the patient and also for us as electrophysiologists if you use all the recent advances and advantages you have of a 3D mapping system compared to cryo. 5 minutes versus 17, 19 minutes. That's really a striking difference, and that's important that you do not withhold this treatment to your patients. Let's go further. Complications. He said there's no difference in complications. Oh, that's easy to say, but if you have a look at the data, you see what kind of complications do we have. Tamponates. There's a legend around that we have more tamponates with RF compared to cryo. But let's have look at the real data. Overall, again, at the line of unity, the complication rate. Numerically higher in RF, but no significant difference. If you have a look at the specific complications, like phrenic palsy, you see significantly higher with cryoablation. I think all of you know patients who have been treated with cryo and come back to you with a phrenic palsy and the permanent phrenic palsy, and we all know how really disabling this is for the patient. Hey, let's have a look again at the most recent data, which Richard didn't want to share with you. So have a look at that. What about tamponates in the circa dose trial? You see just 1 tamponate. So it's arbitrarily, but in the cryo arm, not in the RF. So there is no evidence that you have a higher rate of complications, a higher rate of tamponates with RF ablation, but what you have, you can avoid phrenic palsy. Let's have a look at further achievement, advancements of the technology. We heard about that. Technologies and strategies, technical improvement. On the side of RF and 3D mapping, I see some technical improvements. But I don't want to go too deep into discussion, but on the side of cryoablation, we didn't see too much. This will change, of course, in the near future, but we didn't see too much innovation. We heard and we learned about monitoring of the catheter contact. We are all familiar with that, and we like to use it. We see that the complication rate is rather low with that, and we see also that in this meta-analysis, the freedom of atrial fibrillation can be slightly reduced, but most importantly, due to the monitoring of your contact force, you can really, if you have 0, 1, 2 gram contact force, you can manipulate the catheter in the 3D image without any fluoroscopy, so you have a significant reduction of the fluoroscopy time by using contact force. If you use this and combine it with a very rigorous ablation design and you monitor the lesion-to-lesion distance, as Deutschewer and the group did, then you end up with excellent ablation results with a point-by-point meticulous ablation strategy combined, as Isabel introduced, with the ablation index, combining contact force, stability, power, duration, etc. Then you have excellent results with this old RF technology. And if you have a look, and this was one argument from Richard, he said, after cryo, I don't see the patients with the need for re-isolation. But if you do the meticulous ablation strategy with RF, you also don't see them again. 45 patients who came back for recurrence of atrial fibrillation, just recently published a couple of weeks ago, and you see the rate of completely isolated veins, 62% compared to the historical data with RF, including our own data, which were, of course, bad because we were not good in completely isolating the veins, but that has completely and dramatically changed with all the new technologies we have available. So let's have a look at future upcoming innovations. We already heard about high power, short duration. We sometimes in politics would like to have that, but here we have it as a very, very innovative tool. So we are changing from the standard approach with conductive to more resistive heating using the high power approach. And you all have heard about the exciting results. Isabel has also introduced that, and here are some data also on procedural time, ablation time. So this will dramatically change our way to do the point-by-point ablation, and which is of course not part of the trials and the data I could share with you, but we will see in the future. So my last point, and I think it's an important point, we are not doing standard procedures. We are doing an individualized approach, and we are seeing individuals and not only atrial fibrillation patients. They have specific arrhythmias. Just a very simple case from last week. You see this patient, he had, of course, documented paroxysmal atrial fibrillation, but when he was on the table, he said, okay, these extrasystoles are killing me. Please move them away, put them away. If I put out the cryoballoon, I'm not sure that I can really get rid of them. So what do? I do a mapping, very simple, straightforward, and I see right at the edge of the vein, of the right inferior vein, I see this focus. So of course I put the line accordingly and try to get rid of it, and I can get rid of it. If I do it with a cryo, I can never be sure, and the focus can be, of course, somewhere else, not so as close to the line. So we need an individualized approach. And if I put that all together, I can only say the list pro point by point is very long, and the arguments are very strong. And so for me, it's clear there's only one way. Even though it's nice to see me sitting on a balloon and on the hot needle, but I must say that's the only way to go. And I would like you to hear that song in your ears and to join me, and to also maybe discuss these at the end, discuss these points, who are candidates for one or the other technology. And I would recommend the young guy who has paroxysmal atrial fibrillation, who comes with 40, 50 years and who's otherwise healthy. I would strongly recommend to do a contemporary way of RFC ablation. The little old lady you may want to ablate quite fast, and you want to be have very, very short procedure. Maybe cryo would be nice, but not if there's a renal impairment, of course, yeah, because we have to make sure that there's not too much contrast media in that patient. So we will see future progress. Both technologies, I see much more progress and much more innovation in the side of point-by-point ablation compared to cryo. We will see what will come up. And last but not least, what are we? Are we machines? Are we dummies just putting in these balloons and putting on the pedal? No, we are electrophysiologists. So we'd like to map and we'd like to understand what we are doing. And this is what we are, I think, that's why we decided to become electrophysiologists, to try to understand EP and to understand arrhythmias and to appreciate the individual patients and not just doing simple single shot. Thank you very much for your attention.
Thank you very much. Thanks a lot, Stefan. I will say that our two champions did an excellent job. Very clear, very fair between you. And I would say that the historical guy and the unclever guy have fought very proudly, and I would declare myself a tie between you. But now I think that maybe you want to answer to each other to some question you may have between you, or...
Yeah, well, I think it's always very difficult to sit on a stage with everyone watching you while someone else destroys your arguments and keep a brave face on it. But I managed to keep smiling through most of it. But how many people, can I ask, in the room use cryoablation now? If you can put your hands up. So there's a lot of dummies in here, huh?
Me too.
So there's a lot of dummies in here, and you know, I thought your arguments were brilliant, But you do get phrenic nerve palsy with radiofrequency. It's not looked for, and maybe it probably doesn't happen as often, but it does happen. And we do. You've said that the outcomes from radiofrequency are very similar to cryo in the trials. And you can use less radiation, and you can use very little contrast, if any. So can we really say that that's an argument for giving that poor, very young 50-year-old man? I notice you must be about the same age as me then, if we think that 50 is young. Would you really give that 50-year-old man a point-by-point rather than a cryo when you know that they can be home later on that day?
Yes, of course I would. And I think the data I showed, and sorry to say this, you mainly showed.
You're not sorry though.
You mainly showed the small trials. I also did that, but I also tried to show the randomized, also the recent trial. And if you step aside and have a look at it from the scientific point, you see that in all the randomized trials, the radiation time is significantly reduced, and the difference between cryo and RF has even increased because the innovation on the 3D mapping field has dramatically changed our way. It's not just that we are putting blind the hot needle in the left atrium. So we can really do this, and you know about that we can manipulate without really using fluoroscopy, and I think that's a very important issue also regarding safety. And maybe one point, we don't have any further backup slides, but if you have a look at the monitoring of the endpoint, what do you think about the let's say reliability of the Achieve catheter as compared to, for example, a high-density map to really evaluate your endpoint of pulmonary vein isolation? Is that sufficient, what we are doing with cryo? So it's a simple tool, and I completely agree that for the first-line treatment, so that's why I'm also lifting my hand that I'm of course doing it as well. But for the first-line treatment, for some people it may be okay, but I would strongly support to use it for the patient I said. And I would like to ask you, what do you think about the endpoint evaluation? Is that sufficient, what we do with the Achieve catheter?
Well, I think according to the data, and I'm wandering out here not because I'm scared of you, but I don't want the others to feel left out. I want to be talking to them as well. But I think the data suggests that the outcomes are sufficient. This is like watching sort of Putin and Trump walking along in a conference, isn't it? Yeah.
Who's who?
I'll be Trump. I'm the stupid one. Yeah. But I think the outcomes suggest that they are. You know, that looking at the change in electrical activation on the Achieve wire is a sufficient endpoint combined with the temperature to give just as good an outcome with cryo as that you can get with radiofrequency, as you showed yourself. And I think in answer to your fluoroscopy question, well, of course, the people that are recruiting for these trials are very experienced operators, but even they are only achieving a 5-minute difference between the fluoro times of the cryo and the RF. And actually, when you get really good at cryo, you can reduce that fluoro time to less than a minute. So there's no reason why we have to give high fluoroscopy times to patients. We can learn and train to reduce that if we work hard at it.
But yes, that may be, if it happens in your hand, it's possible. But if you have a look at the available data, it's 5 minutes versus 15 minutes. So 5 minutes versus 17 minutes. So that's quite a difference. And I think also for your career as an electrophysiologist and for the patient, it's relevant. Yeah. And I would also like to maybe make one point, one rather smooth point. But I think it's important. What if you have a fellow in the EP lab who comes to you and says, okay, I would like to become, I've seen you and your career, and I respect you very much, So I'd like to become someone like you. So I'd like to start EP. So what will these lady or these young gentlemen do? Will they say, okay, I'd like to do cryo, or I'd like to do some kind of mapping and point-by-point ablation? What is the attitude of the people coming to you?
Well, as you might imagine, there's not many people that come to me saying, I want to be like you.
Just put it at a virtue. Okay, it's a bad question. Sorry for that.
Those that are desperate enough to do
just
that.
Just imagine they would come to someone who is, something like that.
But we're doctors. The reason that we love the job we do is not because we can disconnect an electrical signal. We love the job we do because we want to see the patient in the clinic afterwards, and they say, thank you, doctor. Thank you for getting me through that procedure and getting rid of my atrial fibrillation. And I had an hour of half pain afterwards, and then I went home and I felt great. And that, to me, is why I do the job.
Yeah, that's of course why we all do the job at the end. But the way to that is, of course, I would also like to say that it's and we know that it's not all about AF.
Yeah.
So when we want to understand complex atrial tachycardia, complex entities of atrial fibrillation, we need to have some knowledge about EP.
Yeah.
And I think if you only go for single-shot balloon, and that's what I wanted to say with EP. I'm also an EP dummy when I'm doing cryo, of course. But that if we would select that as our one and only strategy, then of course I think from the educational purpose and also from the motivation purpose or perspective to go to more sophisticated arrhythmia, we will have a problem. So I think it's important to still have that this option available.
Yeah, but the endpoint for a radiofrequency PVI is exactly the same as the endpoint for a cryoablation. You're just trying to isolate the veins. That's the only electrophysiology you're doing during that procedure. But what you're really doing is allowing the fellow to practice moving their catheter around in someone's heart in a very complex way. Now, imagine a world where we only brought patients to the lab where we had to do mapping when they had atrial tachycardias or reconnected veins. And then all of it is electrophysiology. It's all pure electrophysiology, and the actual catheter manipulation is really minimal, because all we're moving the catheter to is the break in the line of the radiofrequency wide encirclement, hint, hint, or the atrial tachycardia source, the narrowest isthmus in the atrial tachycardia that's resulted from the wide encirclement of radiofrequency ablation.
Yeah, but then you have to find someone who had not too much radiation exposure so far. No, but but you need also to have that skill, of course.
Yeah.
And that's something. So I mean, we are not practicing because we have seen the data. So this happens not because we are just practicing, because it happens because we are used to do it, and because we have a lot of tools who help us to manipulate safely and almost without fluoroscopy, with at least the same good results as with cryo. So I would just make the point that you cannot say in this house, cryo is the one and only and cryo is better. You cannot say that. If you say, this is my preferred strategy because it's simple and safe and straightforward, that's okay. But it's not better because the results clearly underscore the role of point-by-point ablation with regard to safety, but also with regard to fluoroscopy.
So I don't think I can really answer, because I can see that Serge is now asking us for a timeout.
Yes. Thank you very much. Thank you very much, guys. Thank you.
Thank you.
Thank you.
Thank you.
Thank you. I can say that the speakers, the champions, have been selected according to the skills, of course, but also according to the AF and WAVE, because they are exactly at the same level. And I want to tell you that you guys, I love you both. And I want to ask a question to this room. This question was not planned. It's another question, please. Another question. Who is doing cryo? We already seen. Raise hands. A lot of people. Who is doing cryo? Raise hands, please. Okay. Who is doing radiofrequency? Okay. Who is doing cryo and radiofrequency? Okay. Who is doing cryo and no radiofrequency? 2. Okay, 2 guys. I think that 3, sorry. I think that this is important because it shows something that I really believe, and I'm doing both too. I'm not. I say that I'm unclever, like Richard, but sometimes I try to use my brain. Not every day because I'm very lazy, but but I think that is very important. I really liked the last slide of Stephen. I like all the slides, of course, but the last one was interesting because it showed the point. And the point is what? The point is that, in fact, and I go back to my first introduction, if you think that you are going for PV isolation alone, a balloon will do the job extremely well. It's true that at the present time, you show the numbers in Germany, but in France it's the same. I think that in the UK it's the same, in Italy the same. Much more teams are doing radiofrequency than cryoablation. 60, 40, 65, 35, okay. But this will change. I will tell you why. Because for PV isolation, a tool that is specifically designed will work much better, much easier, and if you are going to this point, you will use the right tool. Of course, if you're thinking about doing something else, you showed in your last example extrasystole, other kind of mechanism, looking for substrate, etc., of course you will need radiofrequency. So one is not excluding the other. I think that both tools are interesting, but please use the right one for the right purpose.